This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome to the Neurology podcast. I'm E.J. Hicks, vascular neurologist and VP of Neurosciences at Ohio Health. And today we have a provocative episode focusing on the article, Long-Term Fatigue Following TIA. We've all been taught that TIAs are by definition brief, but new research published in Neurology by Danish stroke researchers from Aalborg University reveals that over half of patients continue to experience pathological fatigue up to 12 months post-TIA. Now, joining me today are the lead authors from Denmark, Boris, Modrau, and Birgitte, Ebbesen. Boris and Birgitte, thank you for being here.
Thank you.
Thank you for having us.
Now, I'd love to know how we got here. Could you explain what motivated your team to explore fatigue in TIA patients, given that TIAs are supposed to resolve quite quickly?
I think it's a quite pragmatic approach because we are all working with stroke patients and rehabilitation for a couple of years, and we realized that stroke rehabilitation and the follow-up is different in different regions of Denmark. And that was especially true for minor stroke and TIA. And in our region, the North Denmark region where Aalborg University Hospital is placed, we have a multidisciplinary stroke team that follows patients with minor stroke and TIA by phone call or a home visit. And they went back with a feedback that despite complete remission of the acute neurological deficit, these patients did not have the same daily function as they had before. So that was the reason where we thought that TIA patients might be especially interested in looking into, because there was no systematic offer of rehabilitation for these patients. So Birgitte actually showed in one of her previous studies that TIA patients had surprisingly high sick leave, which was compared to stroke patients about 1 out of 5, where in stroke patients it was 1 out of 2. So that was the reason where we thought that was something to dig into even further.
I love that origin story. You and your team assess fatigue at roughly 14 days and then at 3, 6, and 12 months. Why that schedule?
We decided on the 14 days based on having some kind of a baseline that was as close as possible to the index event, but also avoiding the very acute phase. And then it was also practical feasible because we are in contact with these patients around 14 days after the index event. And then we wanted the long-term follow-up, and that was why we aimed at 12 months. And then 3 and 6 months is part of the usual follow-up in a lot of different studies. So that's why we ended up on those. And of course, we could have probably benefited of even longer follow-up, but in these patients, there would also be a risk of their impairments being compromised by new events or other comorbidities, because our cohort was around 70 years of age. So a lot of other things might impact their everyday life as well. So that's why we decided on those time points.
Initially, over 60% of patients had defined pathological fatigue, decreasing slightly, but still over 50% at the later follow-ups. That, to me, is quite significant. How do you interpret this persistence?
We also thought that our finding was quite surprising because it was high and we didn't expect it to be this high. It just underlines the need for awareness of lasting impairments following a TIA, and in our case, then fatigue. And we know that fatigue is also present among patients who do not have a stroke or a TIA, but these numbers are higher than anticipated.
Another thing I found interesting was the presence of acute infarction on the imaging wasn't associated with fatigue, but the prior anxiety depression was twice as common in those with reported persistent fatigue. Does that tell us anything about the underlying mechanisms?
Well, the primary aim of our study was to report fatigue prevalence and the level of fatigue, but not so much to explore the underlying mechanism. But it's a good question, and one of our thoughts was that the patients with DWI lesions may be more likely to suffer from fatigue, but that was not something we could confirm. And pre-existing of comorbidities such as depression and anxiety might play a role, an obvious target for further research. Personally, I believe that some kind of neuropsychological reaction to the acute life-threatening disease, such TIA, including diagnostic workup and being admitted at the hospital and treatment and so on, is highly underestimated and may play a role also.
Now, given the findings that were just presented, should fatigue screening become standard in follow-up care for TIA, even if the patients appear, quote, neurologically intact?
Systematic screening could make sense if we are able to offer effective help for the patients as well. And in many countries today, TIA patients are not offered rehabilitation in the same way as stroke patients are. So we kind of did the first step by exploring the prevalence and level of these lasting fatigue. And we might, for a research perspective, also screen further. But we need to know more about why do some patients report these fatigue and how do we help them. So it's not just about only screening, but also to make sure that if we then identify fatigue, we need to make sure that we have pathways to help patients as well.
Now, the study was conducted in a very strong, well-run, single Danish stroke unit, and some of the participants may have had help completing the questionnaires. How can we take the study and extrapolate it across the diverse settings or exploring interventions that we might be able to have to mitigate a post-TIA fatigue?
We assume that different healthcare systems and insurance systems in different countries might influence the prevalence of fatigue. And I think for now, it might be worth to explore post-TIA fatigue in different settings. And the same is probably true for potential interventions. And then we can make some conclusions.
Now, before we wrap up, are there any final messages you'd like to share about the broader implications of your findings?
While we were working on these projects, we became very aware that in the current clinical guidelines, the focus when talking about TIA patients is really much about the acute treatment and the secondary prevention. But our findings, combined with other studies as well, indicate that in the follow-up after a TIA, our focus should be wider, and it should include also being aware on lasting impairments such as fatigue, and be ready also to provide the support that these patients might need. In conclusion, the narrative of a TIA is that it is transient, but that might not always be the case. So we need to make sure that we take care of all the issues that might be there with these patients.
Boris and Birgitte, thank you so much for joining us. The study is titled Long-Term Fatigue Following TIA. And this and other provocative studies can, of course, be found in the Green Journal. Thank you for checking out the Neurology podcast. This is BJ Hicks signing off.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.